New Thinking Aloud is presented by the California Institute for Human Science, Mind, Body, Spirit University, a leader in fully accredited in-person and online U.S. college degree programs in the topics we cover here. Visit their website at cihs.edu.
Thinking Aloud. Conversations on the leading edge of knowledge and discovery with psychologist Jeffrey Mishlove.
Hello and welcome. I'm Jeffrey Mishlove. Today we will be exploring the psychology of shame. With me is Dr. Gerald Loren Fishkin, who is a clinical psychologist from Long Beach, California. He is the author of The Science of Shame and Its Treatment. He is also the author of American Dream, American Burnout. Welcome, Jerry.
Thanks for having me, Jeff.
It's a pleasure to be with you. You're breaking some new ground when it comes to the study and the treatment of shame because you're beginning to look at the neurological components of shame. So let's start with how you define shame.
I define shame. Shame lives in the brain, and recent research has shown that it lives in the basal ganglia, which is just above the limbic system in our brain. That's our seat of emotion.
Sort of the mammalian brain.
We can call it the mammalian brain because it really is. It's not the neocortex. It's the very basic part of the brain where that informs us of who we are, our emotion, if you will. So recent research has shown that is exactly where shame lives as an affect. And as you and I talked earlier, affects are like pre-emotions.
The precursor of an emotion.
It's a precursor of emotion. It informs us that something is happening. We just really don't know what. If it's shame, we'll know shame because when shame is triggered, it affects our sense of self, who we are.
And you make an interesting distinction, an important distinction between shame and guilt.
Shame and guilt are absolutely not the same. And I hope your listeners understand and never use shame coterminously or the same sense as guilt because they're different. Shame is about our sense of self. It is when it is invoked or triggered, if you will. It causes us to feel something about us. We want to disappear. We want to become invisible because it affects something about our sense of self in the world.
In other words, because I feel ashamed, I believe that I'm a bad person.
That there's something wrong with me. I'm not good enough. I'm just not okay. Guilt, on the other hand, is a learned behavior, if you will, and it's when we feel guilt, it's we have broken a learned value, and we may sense anxiety. Now we know, for example, in law enforcement, police officers use guilt, but they use a machine that measures guilt. They call it lying, and that's called the polygraph, and that measures respiration and blood pressure, and it measures the GSR, the galvanic skin response. That's a measure of lying. We don't have such a measure of guilt, or shame rather. We know when shame is triggered, we just want to disappear.
And typically, people develop this affect of shame in early childhood.
It usually begins very early. Shame, of course, we're all born with the ability to have shame, however. But for many kids who are raised in abusive environments, neglectful environments where they are abandoned, abused, violated in some way, that creates a trauma. Okay, an early life trauma. Usually it's before language. Language develops the first half of the second year of life. So when shame is triggered or violations to the child's sense of self, safety and security happen, a child will have these memories, may not remember exactly what triggered it, but they know something has happened that affects their sense of self.
I think you used the term engram.
Engram. Yes, an engram is a place in the brain where learning happens. And there are engrams throughout our brain, but specifically for shame, it's right there above the basal ganglia. It's there in that brain. But the difference between guilt and shame I can't make a big enough case for it.
It's especially important for parents to understand this
Absolutely.
distinction.
You know, in the old days, they'd say children should be seen and not heard. And what does that say? That, well, little Bobby can show up, but you can't talk. He can't talk in a group. Well, that says that maybe Bobby won't feel comfortable talking in front of people when he's older. I don't think shame is a good training tool. Never did. Nor is guilt a good training tool. When we invoke guilt, or when guilt happens, we feel a sense of anxiety. With shame, we just feel a sense of icky. We want to disappear. We don't feel good enough about ourselves.
And typically, a parent might not know any better than to devalue their child through shame.
You know, in my talks recently, it's come to pass that people are talking about shame being generational, and I truly believe it is. When I look at my own clinical practice at families where shame happens, I can see that it's generational. It's one after the other, from grandfather to father to son. It's passed down, or from mother to grandmother to mother to daughter or to son.
Because if you were shamed as a child and you haven't processed
that's right.
that shame, you're going to pass it on.
It's always passed on. That's right. And the issue that I have, or that we see with this, and especially clinically, is kids that suffer severe shame. Something happened in the bonding relationship between a mother and the child. And, you know, when there is good shame and bad shame, and I'm sure we'll get into that.
Okay.
But what happens with shame is that the child never learns to process and feel safe, because through bonding, through that contact that we have with the eyes and the touching and all that, a child learns to feel okay. Mommy is saying, you're going to be safe. Don't worry. No matter what happens, you're going to be safe. But in so many of these families where a child has been abandoned, isolated, neglected, violated, they never learn to feel safe. They never learn to self-soothe. And that's a primary issue I see clinically. So what do? Where do they run? Because we see that 100% of shame-based individuals typically have addiction or emotional mood or some type of emotional problem.
They tend to shut down emotionally.
They shut down and they look for soothing, self-soothing in the form of pills, liquid, alcohol.
The inner pain is so great.
That's right.
That they're not even able to talk about it.
That's right. So they go to that place where we call self-love, liquid love, and that's alcohol. But we find that 100% of my addict patients have toxic shame. Now, 100% of the population doesn't have toxic shame. We all have shame, or the ability to experience shame, but toxic shame is something else. And that's 100% of the, of people with addictions, mood disorders, or personality disorders suffer some form of toxic shame. They never feel good enough about themselves.
And the shame gets reinforced through self-talk.
Self-talk is how I began this whole journey, as you and I talked earlier, and I want your audience to understand that I was listening to self-talk. I was following self-talk. Everybody has self-talk.
That inner voice.
That inner voice. And oftentimes people with toxic self-talk have that toxic shame going on. You're not good enough. It's like an endless loop. And where does this come from? Do children create this on their own? No. It's usually taken in by an adult. Adults say you're not good enough, or stay away from me. We don't want to have time with the child. Whatever that child feels neglected or violated or abandoned, that child's self-talk is going to be really, really bad.
They internalize the harsh voice of a parent.
Right. You know, even Freud talked about this, Freud talked about inculcating the voice of the adult or the abuser, if you will. And we've kind of gotten away with that with our empirical studies and our empirical procedures like cognitive behavioral therapy, which is highly empirical. But this is a whole different approach, because cognitive behavioral therapy doesn't work with treating shame.
Well, you spent much of your career as a cognitive behavioral therapist.
I am am a cognitive behavioral therapist, and I'm very proud of it. But I also know that I lost about 40% of my clinical patients before I started this study of shame to understand how you deal with it. And you can't deal with it through cognitive behavioral therapy, because the minute I started, my patients would bolt. The minute when they started to talk about their wound and the violations, and if I jumped into it like a cognitive behavioral therapist, they would bolt. And
the idea of cognitive behavioral therapy being, well, you just need to readjust your thinking.
Yeah, you know, Bobby, you're really not a bad boy. So why don't we try to adjust that sound in your head? Never worked. Never worked. Because the individual has to expunge. They have to relieve themselves of that toxic wound. And one way to do it is through what I call compassion-based relational therapy, because you have to relate to the patient at their level. You still have to be in charge, kind of, but you have to relate to the patient at their level so they can express their shame. And until and unless they can express their shame, and what manifestation it takes, what form it takes, they're not going to release it at all.
It's about processing as you call it, the affect, the precursor to the emotion.
Absolutely.
Which is something very, very deep inside the brain.
It's very deep inside the brain. It's a wound, if you will. But that wound can be healed, and that's the good news here. Yeah. And it's not, really, it doesn't take years and years and years, like Freud talked about. It doesn't take that much time at all. What it really takes is an intense focus on the traumas. Because unprocessed trauma and unprocessed grief lead to toxic shame.
Well, there are many popular approaches that don't quite get at it. One of them is the use of affirmations as a way of correcting negative self-talk.
Affirmations do not work, and I'm going to take a lot of ridicule, and people, but I can confront it in a positive, in a clinical way. That affirmations might work later on in treatment, just as cognitive behavioral therapy might work later on in treatment.
But when you're dealing with that deep, toxic emotion, it requires a level of processing that, and in order for a person to feel safe to do that, you've got to create a compassionate space.
And that space may look something like having them write a letter to the abuser. Maybe it's mom or dad. I have one patient who he was 13 years old, and he had a 35-year-old neighbor across the street who she was having sex with him. And she used to say that he was inadequate and this and that. So I had my patient, now he's 44 years old, write her a letter. And within the framework of that letter, he was able to cry and scream and yell at her and release a lot of the stuff. Now we're able to talk about it. But prior to that, he was working out, he was building his body, he was doing everything on the outside to bolster himself, to bolster his ego and make himself feel good. But he was still a falling down drunk and had been a drunk for 25 years, an alcoholic. But he is no longer drinking. He's in the program. He's going to AA religiously, but he was able to release the wound by writing a letter. We've done some other kinds of things like visualizations and bringing him into a space where he can see her and talk to her and confront her as an adult.
And it doesn't have to be with the real person there in the therapy room.
No, absolutely not. That's the purpose of guided imagery and guided visualization. That person doesn't have to be there. They can just conjure a face up and be at 6 or be at 12 or 13 in his case. Be at that age, but use your adult voice and confront her.
But sometimes, as you pointed out, in fact, often it happens before a child has even learned language.
That's right. Many of these wounds happen so early. As I said, the first half of the second year of life when language forms, many of these wounds, Jeff, started very early. Birth, some even say, some say even pre-birth. But I think it's from birth on, actually.
Well, how do you process that if it's, at such an early stage before language is formed? You can't write a letter.
No, well, actually, you can.
Okay.
You can write letters. You can write letters to mom and dad. Mom, why did you leave me? What did you do? Dad, why did you beat me up? These are the things that happen.
If you can recall the memory.
Right. Well, remember,
These
things
are
may have
ongoing
happened.
patterns.
Oh, yeah. We're not just talking about one instance or a second.
Yeah.
We're talking about ongoing traumas, things that happen continuously. And while they may have started at birth or started pre-language, there's still a memory of what happened. There's still a voice in our head that says, you're not good enough. And I find that about 66% of the population has that toxic voice.
66%.
About 66% of the population has either some form of toxic shame. They have addictions. They may be addicted to pain medication, some kind of psychotropic. They may be addicted to some kind of other kind of pill, alcohol, some kind of drug, some kind of compulsive disorder, which addictions usually are, or a personality disorder. So they take, there are many different manifestations.
So in other words, what you're suggesting is underlying many other clinical problems, the issue is shame.
Absolutely shame. And we tend not to look at it. As a psychotherapist and someone trained in psychology, all the way up to a PhD in clinical, I find that we have never had that as part of the curriculum.
I don't recall a course on shame, that's for sure.
Social workers get it, I believe, and people that work in addictions get it. But it hasn't crossed over into our neck of the woods until this book. And I hope that now therapists are going to start to look at it and realize if you want to preserve your clinical population, you better look at shame, because that's what we're dealing with. That's the elephant sitting in the corner of our clinical room, our consulting room.
Many years ago, I was a trainer with a company no longer in existence called Omega Seminars.
I remember.
One of the things that we would do is tell the parents in the room to go back and apologize to their children.
Wonderful.
For what they may have inadvertently caused. I mean, parents do it without realizing because it's how they were treated.
And did you get feedback from?
Oftentimes the parents are in tears at that point in the seminar. It's sort of the culmination of a 3-day program. And yes, we got a lot of feedback.
This is reverse shame, isn't it? If there could be such a thing, I don't think there's a reverse shame, but this is where the parent is actually feeling what they have done. But they could never put words to it.
Well, you point out that there are two fundamental affects.
There are.
Shame and compassion.
Right. And I find that these two, and they may seem polar opposite, but compassion is that other affect that I find so important because to me, it's the driving force in treatment. And what makes up compassion? One is, you have to be on the ground with your person. So you have to have attunement. You have to be attuned to who they are.
Right.
And the other one is empathy, empathic understanding. But even more important than the other, we have to have that for ourselves. Because unless we have attunement and compassion with ourselves and have a dialogue with ourselves, because most people don't even talk to themselves in a positive and healthy way. They don't check themselves out. But I find that the more I go through these processes that I'm looking at and that I have helped develop, I think that I find that I am a happier guy. My patients seem happier with themselves because they are attuning with themselves. They have permission to talk to themselves in a positive and healthy, proactive way.
And if I'm compassionate for myself, I'll be more compassionate to other people. And I think I'll probably have an understanding that if something's going wrong in my life, it doesn't mean that I'm a bad person. It may mean that I have some behavior I should correct.
That's correct. Or, we're not going to live in this world unscathed. Things are going to happen to us. It's how we process and deal with it. But the deeper part of all of that, compassion, is love. And I think that love is that guiding thing. Because we can't project love unless we feel it toward ourselves. We can't have a healthy relationship unless we have internal self-love. But if you have that nasty voice in your head barking at you all the time, it's going to be very difficult to project anything but nasty or your own self-loathing. I think that the goal that I employ and look at in my work is love. It really is, at the end of the day, that patients begin to love themselves in a healthy way. We live in a world where self-love is not really a healthy thing to talk about because we become branded as narcissistic. And that's not a good word because we pretty much have a narcissistic society. And I think our culture is a culture of narcissism.
So how do you distinguish between self-love and narcissism?
Well, because self-love is honest. It's on the ground. You feel it. And it informs you, makes you happy. Okay? Narcissism doesn't make anybody happy. Actually, narcissism is like a defense. Yeah. And I think we do a lot of things to overcompensate for narcissism in life, but we don't have to overcompensate for love. It just is.
It suggests to me that people who are overtly narcissistic are probably also shamed and wounded.
Very shame-based and very wounded. And we see that, I see that clinically daily in the populations that I treat. A lot of it is an overcompensation for just not feeling good enough.
Yeah.
Yeah.
And I know I've had friends and acquaintances like that who try so hard to convince me that everything is wonderful, that they're the greatest person.
Right.
And I know that underneath it, they're really hurting. And I suppose it's not always easy for a friend to get a person to open up and share at that level because the pain is so intense.
You're right. I've met a number of people who, show me their big house and their cars and talk about their business and what they have and where they travel to. And that's all well and good, but they're not telling me anything about who they are. And that's the important thing for me. I don't care about what people have. It's not what they have, because we all, as my dad used to say, we all leave here empty-handed. We leave with nothing. It's what we accumulate. But if our goal is to accumulate physical stuff, then I think we've missed the boat. Because I think life is really more about relationships. The first relationship, the first healthy one, has to be with ourselves and the people that are with us, that inform us, that raise us, I think. But in lieu of that, we have to work to become the best, as I say, the best version of ourselves that we can be.
Well, now you have developed this therapeutic model you call compassionate relationship therapy.
Right.
If let's suppose that I'm having a lot of negative self-talk.
Right.
How can I be compassionate toward myself?
Well, you really can't, because that negative self-talk blocks everything internally that's warm and fuzzy. You can't even feel it. Yeah. So we really have to talk about, Jeff, what happened to you? Where did you come from? Who violated you? Yeah. And maybe you want to write down your, certain, your life as you know it, your timeline of your life. And those areas, those things that happened to you, those traumas, those triggers, if you will, that happened to you early along. Like, how did your mom talk to you? How did your dad talk to you? Were they even there? Who raised you? What was the environment like? Let's get into that. Did you have friends? Were your parents social people? All of these things measure up. They all matter. And I think therapists will begin to look at these markers along the road of life to see where trauma existed. And how the child reacted to those traumas.
But isn't it the case that in almost every form of psychotherapy it starts out with a kind of life history?
It does. But, in many respects, I don't think we've used that life history in a healthy way. It kind of tells us who's your mom, who's your dad, are they still living, what was your relationship? But the history of abuse is very important. And many therapists don't do that because that's what I'm looking at all of the time now. What is the history of abuse? Write down your history. Who did what to you? When did this happen? How old were you? And how did you react to it?
Well, you pointed out earlier that when you began your therapeutic practice using cognitive behavioral therapy, 40% of your patients would reach a certain point of crisis, I suppose.
That's right.
And they would bolt.
That's right. And especially those patients of mine that were in 12-step programs, and the most important time that they would bolt was when it came to spirituality, and they couldn't touch it because it is so, they couldn't get their head around spirituality because they were hardcore. They were driven, but they weren't into a place where they could understand, what is spirituality? What does it mean?
Mm-hmm.
What does it mean to feel spirit? What does it mean to float? What does it mean to have a dream? What does it mean to have a fantasy? What does it mean to be proactive?
Something changed that enabled you to get past that crisis point.
Absolutely. And when I began to look, and as I was writing the book, and I was realizing, my God, I'm losing all these patients. I'm losing them because they're not dealing with their trauma.
Mm-hmm.
And once we can get to that trauma, we're on the road to recovery.
It had to do with you becoming more compassionate ultimately for yourself.
I had to go through a process, and I did, where I spent a week learning about some things that were very hard for me to accept.
Mm-hmm.
But as I was able to shift the blame from myself back to where the original abuses and traumas were in my own life, I could see that it freed me up. I became a different person. I no longer had to cover myself up with defenses. I no longer had to posture myself behind my credentials and what I did for a living. I could just be me. And in the process of just being me, I found that wellspring of life. And to me, that's the most important thing I have gained from this. And working with others and helping them understand what their traumas have revealed to them and how they can overcome them has been the best blessing of my life today.
So I guess part of the lesson there is for therapists who may be viewing this video is to work to get in touch with their own self-compassion.
I think we have to do that first. That's the work of the therapist, is to understand who we are first, where our blocks are, what our traumas were. Nobody comes through childhood unscathed.
Yeah.
Everybody has something going on, but it's how they learn to deal with it. It's how they learn to self-soothe. It's how they were soothed.
Yeah.
That I think guides us throughout the rest of our life and makes our life much more meaningful, and it makes us more meaningful socially and relationally as well.
Well, Dr. Gerald Loren Fishkin, this has been a very enlightening and pleasant conversation to have. Thank you so much for being with me.
Jeff, thank you so much for having me today.
It's a pleasure. And thank you for being with us.
Book 3 in the new Thinking Aloud dialogue series is UFOs and UAP, Are We Really Alone? Now available on Amazon.
You can now download a free PDF copy of issue 7 of the New Thinking Aloud magazine, or order a beautiful printed copy.